Good morning. Nice to meet you. Thank you for the opportunity to present our perfusion technique on aortic arch reconstruction. At this meeting, at this conference, I represent the main Russian cardiovascular surgery center named after Bakulev. About 5,000 on-pump cases are performed there annually. In this slide, you can see the dynamics and structure of surgical activity over the last 10 years. I must say that we have no financial or other conflict of interest concerning this research. As you know, the number of the patients who need aortic arch reconstruction is not so big, but you will agree that such cases are especially complicated for perfusionists. Michael DeBakey performed his first aortic arch surgeries under normothermia, but then the perfusion approaches shifted to deep hypothermic circulatory arrest, and nowadays selective anterograde unibilateral cerebral perfusion with moderate hypothermic circulatory arrest is the gold standard. However, due to the numerous complicated cases and excess achieved in descending aortic surgery, visceral perfusion infiltrated in aortic arch replacement. The combination of normothermic brain perfusion, myocardial perfusion, and lower body perfusion is likely to be a new gold standard. Despite the outstanding results received by Gilles de Toati and his team, their hypothermia exclusion seems to be rather risky to many teams, including us. Thus, since 2030, the technique of adaptive perfusion has been developed in our center. This technique suggests several points of arterial access, the usage of selective anterograde cerebral perfusion, lower body perfusion, and, if necessary, limb perfusion. In our early practice, we used for cerebral and visceral perfusion only one pump, but the impossibility to achieve the right proportions in blood flow rate distribution between the two arterial lines were certain drawbacks of this scheme mentioned. The second scheme was able to ensure a more sophisticated connection of extracorporeal circuit. The safety was guaranteed by the master-slave setting of the heart-lung machine we used. To optimize the perfusion process, the universal table set was launched. It makes it possible to switch on various vascular regions and arterial blood supply resources without any interruption in the current perfusion. We studied 58 patients who have been operated on since 2010 till now. 22 patients who received adaptive perfusion in the special department were observed in the original research group. And 36 patients who received classical perfusion in all adult departments were observed in the control group. There were no differences in sex and age in the group studied. As you can notice, the patients from the research group had much more complicated aortic diseases. Acute and chronic aortic dissections made up 95%, and about 90% in the both groups was presented through dissection of the first type. The surgical interventions in the adaptive perfusion group appeared to be more extensive. Thus, in 77% of cases, the complete aortic arch reconstruction was conducted, and in 50% of cases, the prostheses of dissected brachiocephalic arteries were replaced. In this slide, you can see the structure of surgical procedures performed. To ensure the whole body perfusion in the research group, we used the common femoral artery, the right subclavian and common femoral artery, the right subclavian and left subclavian artery, and sometimes CPB was started through the prosthesis of brachiocephalic artery and through the femoral artery. In the control group, the direct cannulation of innominate artery, the common femoral artery, and the right subclavian artery were used. At present, we prefer to use selective bilateral cerebral perfusion, but in control group, the choice depended on the surgeon's preferences. In this slide, you can see the universal table set with the configuration presented here. In this picture, the first step of operation is presented by cannulation of the right subclavian artery. It is a standard scheme with AV division for bilateral brain perfusion. Here is the stage of anterograde cerebral perfusion and cannulas we used. To avoid the consequences of limb ischemia, we performed limb perfusion 3 times. The indication for limb perfusion were CT and clinical signs of iliofemoral malperfusion and urgent surgical procedures. To addition to the standard assessment, we performed thoracic CT, echocardiography. In case of brachiospheric arteries dissection, we used transcranial Doppler ultrasound of the middle cerebral artery with functional assessment of cerebral blood flow. For intraoperative estimation of brain perfusion, we always used NIRS and transcranial Doppler. We have analyzed a great number of laboratory and clinical data, but we couldn't estimate all data because the control group was recruited retrospectively. And it was the main limitation of our study. As you can see, there are no differences between the groups in CPP and cross-clamping time. However, the duration of circulatory arrest was significantly shorter in the adaptive perfusion group. But in comparison of suspected duration of circulatory arrest presented by selective antegrade cerebral perfusion and visceral perfusion shows that the differences are becoming more evident. Despite a more difficult contingent, patients patients fewer renal complications require dialysis and less number of multi-organ failure was observed in the research group. 2 patients from the control group and one patient from the research group had strokes after surgery. And the retrotomy caused by blood loss often occurred in the control group. And the mortality level was also lower in the adaptive perfusion group. We also found that doses of inotropic drugs were significantly lower in the adaptive perfusion group at the first day. And by the end of the first postoperative day, the arterial oxygenation was considerably better in the research group, but it didn't result in the duration of lung ventilatory support. The best platelet preservation in the research group might be connected with the less degree of ischemia perfusion injury after a short period of circulatory arrest. The adaptive perfusion provided more optimal metabolic support, which was proved by significantly lower lactate levels from the end of CPB and until the third postoperative day. Aspartate aminotransferase is an important marker of tissue injury. A steady growth of its level in the control group was observed till the third postoperative day, when the differences became significant. The second and the third postoperative day show considerably higher degree in mesenterical damage in the patients with prolonged circulatory arrest. The amylase levels were also significantly higher. Here you can see the conclusion we have made after research. During the long interventions on aortic arch and brachiocephalic artery, the adaptive perfusion technique provides more adequate support in terms of aerobic metabolism and maintenance, visceral organ protection, and preservation of blood coagulation potential. Thank you very much for your attention.
Well, thank you, Tatiana. That was a very nice paper.
Thank you.
And I think this just tells everybody it's better to perfuse the patient than to have low or no flow at all. One question I have from a practical side, because this connection seems to be very difficult. How do you determine which flow goes to which area of the body? Because usually you show that you have Niels data or Doppler data or pressure data, but it may be that, for example, the spinal cord protection, it's difficult to assess during this kind of perfusion. So what is your answer to that?
Thank you very much for a very interesting question. The first question was about the difficulties of this system. But we think that this table set is very convenient and not so difficult. And it gives us the possibility to use different pumps for different regions. But one pump is always the main pump. And it's not safe, as you know. But our heart lung machine, had master-slave setting, and it is the prevention in some cases of bubble embolism. About the pressure resistance, I want to answer that only this scheme at the beginning of perfusion allows us to check out the pressures, for example, in the right subclavian artery and in the common femoral artery, this combination. When this circuit is interrupted, we haven't such a possibility. Yeah, sure. It's it's very difficult to explain. To explain such situations, we need a diagram, and we need to draw it.
Yes. Okay. Thank you.
Thank you.
Thank you.